real-time PCR approach for eight gastrointestinal parasites provides improved diagnostic capabilities to resource-limited at-risk populations. Presented by Rojelio Mejia from the National School of Tropical Medicine, Baylor College of Medicine, Houston, Texas.
All right, well, thank you very much. So we'll start off with talking about my research interests, which are in gastrointestinal parasites. So basically, overall, there's about 2 billion infections of gastrointestinal parasites of the 6 billion people in the world. They usually don't cause significant mortality, but they do cause significant morbidity, usually in children at their most young stages of life, 5 years old, 6 years old, when development's high. And because of the morbidity and because of the malnutrition, diarrhea, and anemia, they have decreased growth and cognitive delays. The standard of diagnosis is microscopy. It's an 80-year-old tradition of taking a sample and looking under a microscope. Depending on the parasite, the sensitivity is about 50%. It can go up to 90% depending on the worm burden. Generally, what we do is we do 3 different samples on 3 different days, and that can improve sensitivity of finding a parasite up to 90%. But it's very time consuming and it's very skill dependent. Someone who is not accustomed to seeing a Ascaris worm or other type of parasite may not be able to detect it compared to other particles found in stool. So there's definitely a need for more sensitive and specific diagnostic assays. Here's a couple pictures of a hookworm on the left, ova, and a Strongyloides larvae on the right. Here is Ascaris ova, and you can see the L2 moving inside the ova, getting ready to expel. This is all in the nano or micrometer range. And then just so we can remember what an adult Ascaris looks like, it can grow up to 10 to 20 centimeters. Here's the cecum, and they are expelling it. So it's a very large parasitic infection. But in children, you can see how it can really cause a great degree of obstruction. This is a little girl from Paraguay, and you can see her obtunded belly with this amount of worms that was expelled after antiparasitics. So those are ideal pictures. You can't miss an Ascaris worm moving, or you can't miss Strongyloides, but this is what we normally see on a standard wet mount. Black and white. Here, can this be an egg? Could this be a piece of fiber? It's very hard to tell what a parasitic infection is compared to just other material in the stool. So what's the big deal about trying to figure out parasitic infections? So parasites definitely disproportionately affect people in poverty, and there's a vicious cycle of poverty. This is my favorite slide. Basically what you have is you have people in these rural areas, deep poverty. They have increased risk of GI parasites because it's more of a fecal oral transmission. Because of these GI parasites, they have growth and cognitive delays. And because of these delays, they don't finish school, they don't get better jobs, so they have decreased income and then continue the cycle. So the problem, to stop the cycle, better diagnostics are needed, especially with a test that is so poor, 50%. So can molecular diagnostics, something that we use nowadays in the hospitals here in the Western or at least United States, can these be used to survey these resource-limited areas? It has to be inexpensive. It has to be easy to use. It has to be very sensitive and specific with the first sample. And instead of just taking samples and bringing them back to the States, we actually want to transfer this technology to the study area. So we chose a real-time PCR. It's a quantitative assay. We picked the 8 most common parasitic infections. You can see Ascaris, the worms. Here's the 2 hookworms. Cryptosporidium, Giardia, and Entamoeba, the protozoa, Strongyloides, and Trichuris, also helminth infections. These are most commonly found. The field site was our collaborators in Ecuador. Here's a common house in the rural areas of Ecuador in Quinindé on the Pacific coast. We chose 400 patients, 13 months old. These were both symptomatic and asymptomatic, all comers at that age group. We also chose another group that was 125 school-age kids, ages 8 to 14. These were screened out, and these were all asymptomatic. Now, these children also received albendazole and ivermectin, and we looked at pre and post-treatment. So results. So you can definitely see here that qPCR is more sensitive than microscopy for the 400 children. Red is PCR, and blue is microscopy. For the first one, which is Ascaris lumbricoides, you can see how we had a 7% rate of Ascaris found with PCR, with only less than a 5% or a 5% rate found in microscopy. So we gained a few more detection. For Cryptosporidium, we both look at parvum and hominis because they both are a pathogen. And you can see here, we were able to detect 5% of the children with crypto. And even though we did a modified acid fast stain for the Cryptosporidium, we saw none with microscopy. So PCR was able to detect DNA of Cryptosporidium in 5%. For the hookworms, we found a few children with hookworm with ancylostoma. Necator is this one here. It's another form of hookworm, and that's not typical found in that part of the country. For Strongyloides stercoralis, we also found a few children, while microscopy didn't find any. But the most striking differences are with Giardia. And you can see in red for PCR, we had 30+% of children with Giardia DNA in their stool compared to 5%, 6% with microscopy. So a 5 to 6-fold increase, which is impressive. For Entamoeba histolytica, it appears that microscopy is more sensitive and detects more, but Entamoeba histolytica is a pathogen. Entamoeba dispar looks just like histolytica on microscopy, and it's a non-pathogen. Our assay looks at DNA, and it can tell the difference. So the blue overcalls the amount of Entamoeba histolytica. So it's not a true Entamoeba histolytica infection, but well, ours is. And then we also were able to detect trichuris, which was statistically significant. So another thing when people are interested in GI parasites is worm burden. And what we do is we do something called a Cato-CATS, which is KK, and you just count the eggs in a stool sample. So we compared our PCR, so this is Ascaris DNA, this is Trichuris DNA, to the amount of eggs seen by both parasites, and you can see how the more eggs seen on stool, the more DNA collected. It had a great Spearman value, a great biological Spearman value, and it was statistically significant. So we can also use our assay to determine worm burden. What I'm more interested, though, is co-infections. So typically in American medicine, we find an infection, that's it, we're done. But in parasitology, we're actually more interested in co-infections because it's not just one infection that's causing an issue, it's more than one. So if you look at microscopy, this dark blue, this is 0 parasites. Microscopy found 87% of the kids with 0 parasites, when in reality, we said, no, 61% had 0 parasites. For red, which is 1 parasite, microscopy said 12% parasites were seen. We actually found 30% of the kids with parasites, so twice as many kids diagnosed. More interesting was, though, 2 parasites, the co-infections. You can see here in green, we found 7.5% of the children with 2 parasites compared to 0.8%, so 10 times as many diagnosed. And then we were able to find 3 and 4 parasites with the microscopy. This is just a Venn diagram, just also showing the 2 predominant forms, and you could see how Giardia is the majority with PCR, and you can see having Giardia and Ascaris, we found 15 children, 14 plus 1, compared to just 1 with both Giardia and Ascaris. So 15 times, 10 times the amount. To follow up, to follow up, we had the final result was the Ascaris and Giardia in the 8 to 14-year-old children. You can see that before albendazole, we had 30% of the children with Ascaris, and they all went down to 0. There was a couple that popped up, and these were probably infected post-treatment. For Giardia, they were not treated for Giardia. They didn't get metronidazole. So you could see that about 30% remained positive. So you can use this assay to look at post-treatment efficacy. So in summary, PCR is more sensitive and specific than microscopy. It can distinguish between the species. It can identify co-infections better. It can look at post-treatment efficacy. And we can really use it for epidemiology study. And the more important point is that my whole goal was to bring the cost down so we can do all these assays for less than $1 for all 8 parasites. And really just to acknowledge this was all done for my fellowship at the NIH, and I want to thank them and the people in Ecuador. Thank you.
Okay, we have time for one quick question.
Please. So we have all that data, and we're going to do that next. So my next project is I'm going to go back to Ecuador, and we have the moms of these 400 children. It's actually 2,500 children, but we just wanted to get a good statistical value. We have them at 6 months, 13 months, every 6 months up to 8 years old. So we're going to come in and look at diarrheal effects, what's the most predominant cause, and we're going to do a huge study. Yes, and then that's the nice thing that Phil Cooper, the one in Ecuador, these are clinical children, so they come in, they have growth rates, hemoglobin, and things like that. Great.
Okay, thank you so much.
Thank you.
Next up in this room,